manage 2 hour. So that discussion helps too much because
Yes.
the discussions, you can memorize the discussing points and everything, because we don't practice every points, every
Yes.
specialty. Yeah.
Yes.
I used to
Yes.
Dr. Abhijit,
practice.
Dr.
Yes.
Abhijit, actually, I set up this thing, and this will be like this is directly
Yes, too much.
live in
Because
YouTube. So I think you can start, and I am grateful to you for giving your time for the betterment of the candidates, and extremely sorry for the waiting. Thank you. I think we can start, Dr. Abhijit.
So, good morning, everyone. Today, actually, I want to take the class regarding my exam experience in two parts. Today, I will cover the first part, that viva part. So, first of all, I want to acknowledge that with the blessings of my Thakur, Sisi Thakur, Ankul Chandra, and also the immense support of my parents, my wife and kids, and actually the whole team effort of MVP Muthuswamy group actually makes the dream to become true. So and all the students at that time in the group, we made small groups, we read, we discussed the topic among ourselves, and also attended the classes of MBPO group. Our sirs, ma'am, especially Madhuswamy sir and Dr. Kaushik, we have made it possible even with the busy schedule. And in my time, I read Kansky at least 3 times. And after that, I take help of the book of like Ong, Timothy, and past experience. I tried to finish. I made to finish 7 years experiences, and also Cakewalk and iWiki. I used to see the topics in my busy time in iWiki. I always check what points I am missing, and most of the thing, the discussion part, making group and discussion part. So I am starting my day like, yeah. So my first table was Viva. My first table was medicine and neuro. So my first question, actually, it was written in a paper, like an old known diabetic patient waiting for cataract surgery, sudden fainted and sweating. So they asked me, what would be your DD? So as the patient is diabetic, so and there's history of fainting and sweating. I told them it might be case of hypoglycemia, or might be case of acute myocardial infarction. So then they asked me, how will you approach? What would be your treatment approach? So I told that I immediately rush to the patient, and I will secure the safe environment, and quickly I will assess the patient's orientation, and then call for help. And then I will check the airway, and I will check the breathing status, and SpO2, and I will check the circulatory status like pulse, BP, and immediately I will see the blood glucose level, that is bedside monitoring of glucose with the glucometer. I will see whether it is there is fall of blood sugar, and I'll try to arrange for 12 plate ECG. So they immediately intervene and interrupt and ask me, you have seen that there is hypoglycemia. So what you will do? So then I say patient is fainted. Then I assess the consciousness. Is if the patient is little bit conscious, patient can take by food himself. So I will offer some sweet food like orange juice or candy, something like that. Around if there is availability of orange juice, around 200 ml of orange juice I will give, and I will reassess the blood sugar level in 10 to 15 minutes. The blood sugar level is not normalized, then I will offer again. I can offer that sweet food at least 3 times. most of the time it regain. But if the patient is unconscious, he cannot offer sweet food. So I have to go for intravenous glucose. It is 10% glucose. So I can give the patient around 200 ml over 10 to 15 minutes. So again, the same thing, I will recheck the glucose, whether it is becoming, it is normalized. If not, I can give it twice or thrice. By this way, I can treat the patient. So, says one of the examiners said, if you are not finding any vein for intravenous infusion, so what will you do? Then I said I will offer uh, injection glucagon, IM or IV. So they left me for they left the question and give me the next one. Next in the next paper, they shown me a scenario like a middle-aged patient waiting for waiting for surgery, develop fit and become unconscious. So what is your diagnosis? So before going to direct answer, I asked, may I know the duration of it? They said it's around 5 minutes. So I told it is an acute fit attack. So one of the examiner asked me, why you are asking about duration? Then I asked if it is more than 20 to 25 minutes or there is several attack without any interval period of consciousness. So it might be diagnosed as status epilepticus. Then say, okay, okay. So how will you approach? So I've started the same manner by like the first question, like I will secure the safe environment, call for help, and uh, and then ARA. And in ARA, I added that there might be secretion, so I will clear it gently, and I have to prevent the tongue bite, and then breathing and circulation. Though they said it's okay, okay, proceed. So then I proceed like I will immediately check the blood glucose level, and I will send the blood for for assessment of sodium, potassium, and I will arrange for ECG. So then what you will do? I told that I will give IV lorazepam 4 milligram. If it is not possible, then I will give buccal midazolam or rectal midazolam. So they asked me, will you offer lorazepam midazolam very beginning? Then I told that I will, if there is any definitive cause, like if there is hypoglycemia, I will correct hypoglycemia. If the patient is non-alcoholic, then I will give IV thiamine. And then if there is presence of hypovolemia, I will offer saline infusion. So then they ask how long you wait. I told as it is an acute feet attack, I cannot wait too much. Patient should be resuscitated with this measure within 20 to 30 minutes. Otherwise, there will be brain injury. If it prolongs, patient is not recovered within that period, I will call for anesthetist, ICU persons for consideration of general anesthesia. So they stopped there. Then my next case was like again a scenario, a middle-aged woman with ptosis, and they have mentioned there was diurnal variation. So they straightforward asked me, what is your diagnosis? So as I told, the statement shows that it's a middle-aged woman and there is ptosis and diurnal variation. So with the history, I am assuming this is a case of ocular myasthenia, but to confirm my diagnosis, I will go for several steps. Like I will clinically examine the patient to exclude there is a presence of fatiguity, and I described that I will ask the patient to see up for at least 1 minute. I will see the whether the patient can attain that up gauge for that duration. And then I will see the cognitive sign. Like I will ask the patient to see from downwards to primary gaze. So there will be some twitching movement of eye that is known as cognitive sign. Then if this is positive, I will do some test like eye spec test. I described the test. They both are hearing what I was telling. So I told like I will press the ice pack covered with some cloth for 2 minutes, and I will observe. If and then to confirm, I will do the hydrophonium test. So then they ask, what do you do in a hydrophonium test? So I told before doing the test to reduce the complication, I will give IV atropine. Then first I will give 0.2 ml of hydrophonium uh, shortly, and I will assess whether there is any improvement of ptosis or any adverse reaction. If there is any improvement or any adverse reaction, I will stop there. If it not so, there is no definitive sign. There is no definitive improvement. I will give next 0.8 ml or 8 milligram hydrophonium, and I'll assess the any ptosis in improvement and any motility, the rest, any change in the motility. So the effect lasts for 5 minutes. So with this, I can go for a diagnosis that if the findings are positive, then I can term it as ocular myasthenia. Then they said, do you want to confirm with some investigation? Then I said I will go for blood investigations, like go for antibody test for anti-acetylcholine receptor antibody and anti-musk antibody, anti-muscle specific kinase protein kinase antibody, and anything else anti-striational antibody. So then anything else, they asked me anything else. And then I told that I will go for CT thorax to exclude any presence of thymoma. Again, they asked anything else. Then I told I can go for thyroid testing because there may be presence of thyroid abnormality. So they can go. They go for. They asked me that what treatment did you offer to the patient? So then I told that I will first I will give anticholinesterase agents like pyridostigmine. If the patient's ptosis and ptosis is severe, and I can offer the patient along with that, I can offer steroid excluding the contraindications, or sometime steroid sparing agents when steroid can be offered. In case of acute symptoms like respiratory problems, severe ptosis, we can give IV immunoglobulin, and sometimes we can offer plasmapheresis. So then they stop there. So here I want to ask people anything you wanted, because 3 questions from medicine part. Anything you want to ask, then I will proceed to the next.
Yes. Right, sir. The doses, so just the important doses, for example, lorazepam, you mentioned 4 mg. So just the doses of a few of them are important, but not everything, right?
No, actually, they don't ask me the dose. I myself told the dose, but sometime doses which medicines are being used and which is typical for that disease. Remember
Right.
that. Nothing. All the doses is not important. All the
Right.
doses are not important.
Right.
Did they ask about EMG, single muscle fiber EMG?
Actually, they next I feel I could tell the EMG and muscle biopsy. But in exam I forgot that, but they don't mind.
Yeah. Okay.
Anything? If not, then I can proceed to my next questions.
Yes, sir. It's quite
Okay.
clear so far.
So Yeah. So, yeah. So then they showed me a picture, and in the picture it is been noted it's a 30 years old male. So they asked me to describe the picture. So I started like it is a fundus photo of both eye. Her right eye showing blurring of disc margin. There is hyperemia, uh, and the left side disc margins are normal, and the fovea both side apparently normal. The vessels look like normal. So then ask me, what is your differential diagnosis? So then I told that on, depending upon the picture, it might be a case of papillitis form of optic neuritis, or might be uh, some right-sided optic nerve compressive lesions, or right-sided trauma. So they told me that uh, what feature will tell you it might be a case of optic neuritis. So I told them clinically there will be decreased vision, there will be pain on eye movement, there will be reduced color vision or color saturation. Saying this through, they stopped me. Then they told that if it is a case of optic neuritis, what you will do? So, and then I told that I'll investigate the case. So they asked me how I'll do MRI. I'll do neuro-imaging, like magnetic resonance imaging. So they say, what is the significance of doing MRI? So I told that MRI is been done to rule out any lesions in periventricular area or around optic nerve. So they asked me, if you find any periventricular lesions, what it signifies. I told if there is a presence of periventricular lesion, the chance of occurrence of multiple sclerosis will be there. Like data shows, down the 15 years down the line, there will be chance of 70% of occurrence of multiple sclerosis in this patient. So then they asked me what treatment you will offer. Then I told, excluding the contraindications, I will offer the patient intravenous methylprednisolone, 1 gram per day for 3 days. Then I will offer oral prednisolone 1 milligram per kg body weight for next 11 days. Then I will taper oral prednisolone in 3 to 4 days. They asked me, yes, okay, anything else? Then I told them if there is a contraindication, then I can contraindication of corticosteroids. We can consider some immunomodulators like
Dr. Avijit, did
glatiramer.
you tell MRV also?
Sorry, sorry. Please ask me again.
No, if there is bilateral, yes, no, no, if there is bilateral, that is papilloma, then MRI is papilloma.
Actually, I told only MRI.
Hello.
I don't say anything else. Am I audible now? I
Okay.
think there's
No,
some.
no, no, just I am saying if there is a papilloma,
And I haven't told. I just say neuroimaging and then MRI. The questions go on that way. I don't say MRI. Okay. So will I continue?
Yes, sir.
Yeah. So then have some immunomodulators like glatiramer or interferon beta, and some monoclonal antibody like alemtuzumab, ocrelizumab, natalizumab. So like that, then they other examiner asked me, if you feel that age is important, you have directly said the papillitis form of optic neuritis. Is there any importance of the age? And yes, sir. So how explain? So then I told if the patient's age is around like near about 60, then my diagnosis will be go for non-arteritic AI1. If it is more than or near about 70, then I should think of arteritic variety of acute ischemic optic neuropathy, anterior ischemic optic neuropathy. So then they stop there and they go for next question. They asked me to describe the picture. So I started like this is a picture of a child who is showing on inspection showing apparently there is esotropia and in harshback. Actually, in my case, here the harshback is just near the pupillary border. Actually, in my case, it was in midway between. So I stated like that on Hirschberg test, the light reflex is in between in the pupillary border and limbus. So there is on Hirschberg there is 30-degree esotropia, or you can say it's 60 prism diopter esotropia. So then they asked me that what is your differentials in this patient? So I told it might be a case of infantile essential esotropia or congenital esotropia, or it might be a case of congenital six-nerve palsy, or Duane's retraction syndrome type 1. They stopped me. So they told me how you can differentiate. What do you say now? So I told that there is some feature which will suggest it might be a case of essential infantile esotropia, like there might be presence of alternate esotropia in primary gauge. There might be presence of cross fixation in alternate gauge, on-site gauge, and there might be presence of lateral nystagmus. Then they stopped me there. They asked me that how you can exclude it is not a case of congenital six-nerve palsy. Then I told that I will do the ocular movement examination. So how I will do? They asked me. So I told that I can do rotating movement or Doll's eye head movement to exclude congenital six-nerve palsy. Then you said Duane's, how can be differentiated here? So again, I told with the movement, if there is any co-contraction of the leads in adduction, it will tell it is a Duane retraction. So then they go for tell about the essential esotropia. Then I told them what are the other features they asked me. I told there may be presence of lateral nystagmus. There might be presence of manifest lateral nystagmus. And some patient will develop infraoblique overaction over the period, like after 2 to 3 years. There might be dissociative vertical deviations. Again, it may develop later. And in such kind of patient, if it is a case of infantile esotropia, the refractive errors are not that high. And then they stopped me. They told me that if you are saying that it's a case of essential infantile esotropia. So how will you manage? How will you treat this patient? So then I started that I will do a full cycloplegic refraction. If there is any refractive error, I will correct that. Even though in infantile esotropia, refractive error would not be that much, but still whatever will be present, I will correct that. And if there is any presence of amblyopia, I'll go for amblyopia correction first. Then after certain period, like after 1 year, then I will offer surgical treatment. So then they asked me prior to surgical treatment, what you will do? Then I told I will counsel the parents. So what counseling you will do? And then I asked that you have to stick to the treatment for a long, even after surgery. Child have to wear glasses, and immediately after surgery, there might be some under or over correction, which will be treated accordingly. Don't be afraid of that. And after a while, even after a successful surgery, child may require subsequent surgeries because of some other reasons. So I want to focus that even after surgery, there might be infrared overreaction, and later there might be dissociative vertical deviation. So it needs surgical correction again. So they stopped me there. Anything else you want to do? Actually, I missed that part. In the DD, there might be secondary esotropia, sensory esotropia. I missed that part. So then I again told that actually, sir, I want to do a dilated fundus examination. Then they smile. So why? So I want to do secondary causes like any sensory depravement, like any cataract or any retinal issues like retinoblastoma. I have to exclude that. So they smiled and they stopped there. So they show me a picture looks like that. So they asked me describe. And they asked me to describe. So I started from a primary position. It's normal in dextro version. The movements are normal in levo version. There is limitation of left-sided. There is left-sided abduction deficit. And then in dextro elevation and dextro depression, moments are normal. Levo elevation, levo depression, there is lateral side movement is restricted. So they asked me, what is your differential? So then I told there is left-sided abduction deficit. It might be a case of left-sided lateral rectus palsy, or it might be there might be some mechanical cause like Duane retraction syndrome or some restrictive pathologies like thyroid myopathy or traumatic entrapment. So then they ask, how will you differentiate? I told I will do forced action test. So what will be the impression? So I told if forced action test is positive, then it might be a restrictive pathology like thyroid myopathy or any muscle entrapment following trauma, and some endurance also. If the forced action test is negative, then it might be a case of left side is lateral rectus palsy. So then they asked me, if it is a case of left-sided lateral rectus palsy, how will you manage this case? Then I told them that in considering lateral rectus palsy, I have to exclude some life-threatening condition first, like it might be a case of raised intracranial tension secondary to any CNS tumor or malignant hypertension. Rarely, it might be dural sinus thrombosis or meningitis. And I have it might 6-nerve palsy might cause in some benign conditions like benign idiopathic intermittent hypertension, or some microvasculopathies like diabetes, or any trauma like that. So first, to exclude all these things, I will take quick history, like is there any presence of any headache, projectile vomiting, any history of uncontrolled hypertension or any history of fever, to exclude all the life-threatening conditions what I told, and any drug intake, and then they asked me what else you do. Then I after taking history, I will do the fundus examination to rule out papilledema. If there is any papilledema, I have to rule out SOL, space occupying lesions. So if there is presence of life-threatening conditions, like I have to manage the patient in collaboration of neurologist and in collaboration of medicine internist. So then they stopped there. They didn't ask me more. And yes, I am stopping here. If you want to ask anything, just you can ask. Anything to be added here?
Did they ask about the neuro-imaging? What will be better, whether CT or MRI, with the contrast or without contrast, which is better one?
Yes, sorry. I have missed that. I have missed. Yes. They also asked if it isn't benign or like I told that said it might be a case of idiopathic intermittent hypertension or microvascular.
Yes.
They asked me what you will do. So then I told that I will consider the age and I will examine the patient for any presence of any other neurological signs like fifth nerve involvement, seventh, eighth nerve involvement. So I told in the manner if the patient is less than 50 years age and the presence of neurological abnormalities, I will do neuroimaging immediately. If not
Hmm.
so, if the patient is more than 50 years age and there is presence of obvious microvascular patterns or diabetes, I'll observe the patient up to 3 to 6 months. If there is no improvement, then I will go for neuroimaging. And if the patient has any associated findings, like even after 50, when a patient's age more than 50, but there is presence of the features of other cranial pulses, other neuropathies, then I will go for neuroimaging. And if there's any presence of any pathologist, I'll treat the patient in collaboration with neurologist. Yeah, I missed that part. Yeah. Okay.
So
Anything?
which is more better option? Like we should go for CT, NGO, or we should go for
They
MRI?
didn't
Which one
ask
is
me
better?
this. In such
Yeah.
case,
Hmm.
I think MRI should be better to exclude any
Okay.
neuronal lesions. Like I think MRI will be better. I think neurologist or neuro-ophthalmologist will give you the better answer. But if they
Hmm.
ask me in exam, I would tell magnetic resonance imaging
With
of,
gadolinium or like that.
of brain better.
Hmm. Okay.
If nothing else, I can move to my next part. Actually, there are 6 cases in my the first part, neuro and medicine.
Yeah.
Okay,
Okay.
I am moving to next
Yeah.
part. So my next table was anterior segment and oculoplastic. So my face first case was like a picture looking like that. So they asked me to describe. So I told it is a anterior segment photo of a photo which showing the conjunctival cornea is clear. There is presence of posterior synechia, and there is presence of quite cataract. Though they asked me, what is your impression? I told it is a post-uveitic cataract, post-uveitic mature cataract. So they asked me, what is your plan? I told that I will go for surgical correction. I will go for cataract surgery with eyelid implantation. So they asked me that what will be your pre-op consideration. Then I started like before going to surgical plane, I will assure that there should be at least 3 months of uveitic free interval. There should not be any cells flare within 3 months. There should not be any pain. So it should be assured, secure, confirm first that there is 3 months UVD free interval period will be there. And prior to planning for surgery, I will start topical steroid 7 days before surgery, excluding contraindications. Then they asked me that what will be your intraoperative considerations, and then I told that as it is a mature cataract and there is presence of posterior synechia, I will and people is not dilated properly, I will consider people expanding agents.
Dr. Avijit,
Yes,
Dr. Avijit,
yes.
preoperative workup, I think ultrasound should must be done because sometimes such cases can happen with retinal detachment. Chronic
Yes,
retinal
yes,
detachment
yes,
can
yes,
cause similar type of cataract.
yes,
So
yes,
that
yes,
has to be done. And also projection of rays. We
yes,
have
yes.
to check the projection of rays.
Yes, I mentioned in my exam, but here I have forgotten. Yes, as it is a mature cataract, I mentioned ultrasound by microscopy to exclude any posterior segment pathology. Yeah, thank you, Dr. Kaushik. Then in intraoperative, I told need of people expanding agents like. So they asked me anything you can name. I say Bhattacharya ring, BHEX, and Maloging ring. Okay, then next, then I told them I will consider OVDs like visco cohesive agents and adaptive agents to protect the cornea, as it is a it's a hard cataract, natural cataract. Then they told me, yes, intraoperative you managed. So what will be your post-operative considerations? So in such case, as it is a case of post-uveitic case, there might be chance of post-operative uveitis. So I asked them, I told them I would add frequent topical steroid, cycloplegics, and I will examine frequently, and I will examine the posterior segment. I will do the ocular fluorescence tomography of macula to exclude cystoid macular edema, because there is chance of cystoid macular edema. Okay, so then they didn't ask anything more here. I'll go to my next question. After 3 questions, I will ask you people if you want to add anything. So the next scenario was during phacoemulsification, there was sudden shallowing of anterior chamber with altered fundal core. So they asked me what is your diagnosis? So in such scenario, I told it is a case of suprachoroidal hemorrhage. So how you will treat the patient? So I stepwise I start telling that I will immediately ask my assistant to give me suture to close the suture. Then I will and if there is an in between, I will try to give give OVDs in the AC if it allows. Then they interrupt me, like if there is some delay, your assistant are not able to manage to give you the suture immediately, what you will do? I thought I told I will give OVD, try to give OVD, even though sometimes it will not be possible. So there's a pause. So I thought what I can do, even before suturing. So I told that I can put my finger on the wound to stop any leakage. So then they proceed. So then I told after suturing, I will offer mannitol excluding contraindications, and I will start anti-glaucoma medications. And what else you do? I told if I have a ear surgeon near to me, I will take immediate help. So what they will do? I told them they used to do the drainage of suprachoroidal hemorrhage, and sometimes it may be associated with parsplantar vitrectomy. Then they ask that if the VR surgeons are not available, what you will do? Then I told them after doing all these things, I will add anti-glaucoma, full coverage of anti-glaucoma, excluding contraindications, and then steroid and cycloplegics. And immediately on that day, I will refer the patient to my VR colleague. They will assess, and what we told, like the management, they will take care of that immediately. So they want to hear that what you will do, like there is no VR surgeon. So what there should be a protocol, like you should give full coverage of anti-glaucoma, excluding contraindications, cycloplegics, and steroids, and you have to refer the patient on that day. Don't make any delay on that day if possible, and they will manage accordingly, like drainage of suprachoroidal hemorrhage along with or without parsplantar vitrectomy. So they move to next question. Actually, my next question is, it was a picture. There was gross one eye. They have given me one eye picture. There's gross haziness of the cornea, limbal ischemia, and it has been written. It is an alkali brand. So they asked me, how will you assess the severity of this patient? Then I told that I'll assess, like I told considering the Roper Hall, it is a grade 4 chemical injury. So why I was saying it's a grade 4? Till the Roper Hall classifications, then I told Roper Hall classifications. It's a grade 1 corneal epithelial defect will be there. No limbal ischemia. Grade 2 limbal ischemia less than 1/3. Epithelial defect will be there, but the beyond details is clear. But in grade 3, it will be limbal ischemia more than 1/3 to half, and grade 4 limbal ischemia is more than half. Here, the picture was like almost 3/4 of the cornea is involved. So I told them it is a grade 4 chemical injury according to Roper Hall. So they asked me any other way of assessing severity. I told Dua's classification also there, Dua's grading also there. So what they consider, what they included, I told conjunctival involvement is only included. Though they don't go for the detail of that. And then though they ask me rather than these two, anything else, then I asked that I will try to actually the central part was little bit clear. Almost the peripheral part, this peripheral and the mid peripheral cornea was involved. So I'll try to see the anterior chamber reaction, though it is might not be possible, but I'll try to see anterior chamber reaction. So okay. So then how will you treat the patient? I will immediately do copious irrigation first and ensure there should not be any residual particle by everting the leads. And if there is any necrotic tissues, I will deprive that. Then immediately after that, I will start frequent topical steroids, which will be a pulse therapy, which will be like up to 7 to 20 days, not continuous therapy. And along with that, topical antibiotic, topical cyclovasic drops, and I will consider oral vitamin C, the dose like 500 milligram 3 to 4 times, and oral doxycycline. So they asked me after immediate management, what you will do. As this patient has grade 4, so immediately I have to think of like restoration of the limbal stem cell. Otherwise, there will be more complications. So how will you restore? They asked me. So some surgical options like tenons. That means tenons. What I told. Just let me remember. Actually, I told tenons. 1 minute. Yeah, remember. Advancement of tenons capsule. I told advancement of tenons capsule.
Okay.
What else? Limbal stem cell transplant and amniotic membrane graft. So these are the early treatments to be offered to the patient to restore the limbal stem cell. And then what treatment in the long run you will offer? Then I told if there is a presence of symblepharon or encaloplepharon, it should be taken care of. And if there is any skin, like if there is any cicatricial entropion or ectropion, that should be taken care of. And when the inflammatory conditions subsided, and if there is any central corneal opacity, then we can consider keratoplasty. If the injury is severe and if there is bilateral involvement and all the prior options are failed, then keratoprosthesis can be offered to the patient. So they stopped there. So anything you want to add?
Yes. Did they ask you about the differential diagnosis since it was just a picture, or did they say that this is a case of chemical burn?
They have mentioned.
Okay.
It's but it might be that scenario also. They may skip that word. So there is will be little bit more discussion. Alkali burn, acid burn, like that way.
Right. Right.
Yeah.
Okay. Okay. Thank you.
Okay, then I can proceed to the next one. Actually, this was not the case. I couldn't find the actual picture which resembles the case given in the exam hall. There's a huge swelling. Like upper lid, almost 3/4 of the lid, upper lid was been involved. So they ask me, what is your, they don't ask me to describe the case here. They directly, to save time, they directly go for your differentials. Then told it might be a case of sebaceous gland carcinoma, squamous cell carcinoma. Then I stopped whether I will told basal cell carcinoma or not, because it's not looking like that. So then ask me any benign condition with that swelling you think of. I was puzzled that much of swelling and benign condition, but still they are asking. Then I told with 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 little bit confusion, but still I told benign. It might be case of keratoacanthoma. Then they smiled. Then they started. What are the risk factors for keratoacanthoma? I told fair skin, sun exposure, some immunosuppressions, renal transplantation. So then they ask, what might be the histological picture of this patient? Again, I have forgotten the actual statement. So I remembered that keratin field crater. So I told there may be presence of keratin field crater. So they stopped there. Actually, anything else? They asked me anything else. I have forgotten. Actually, there's some shoulder formation or something like that. You will write in test. So they asked that part also. So they told me that what treatment you will give. If I told them, if I think it is a case of keratoacanthoma, first initially I will observe the patient as it is benign condition. Sometimes there is spontaneous resolution of the swelling. So that they told only observation. So what else? Then I told if there is any progression, like there is no resolution, then I have to think of surgical option. So they asked me that if it is not been resolved, what else you will think? I told there may be it might be transformed to some malignancy. So what malignancy? I told squamous cell carcinoma. So okay, proceed. So what treatment do you will offer? Tell again. They asked me. So I told them I will do an excision biopsy and send the material for histological confirmation by frozen section or most microsurgical technique. So they asked me like when like so much of large defect, what you will do? So I will in collaboration of my oculoplastic clinic, I will offer cutler beer reconstruction surgery. They stopped there. My next case was this picture. So they asked me to describe. So it is a picture of right-sided face, which showing the lower lid ectropion with cicatrix, where the lower fornix is visible. The rest of the part is normal. So they asked me, what is your impression? I told it's a cicatrical entropion. Then they directly go for, they didn't ask me cause or something. They directly go for management. How will you manage? So as I told them, as the fornix is visible, it's a severe cicatrical entropion. I have to offer surgical treatment like removal of scar tissue and the reconstruction of the anterior posterior lamella. Then they asked me what you will, how it can be reconstructed. Then I told that there might be a skin flap or graft to be done. So they asked me from where you can take the graft. I told them upper eyelid or pre and post-auricular area or supraclavicular area. So then they leave there. They didn't ask more. But and my next question was like describe this. Then I told it's a intersegment photo which shows there is a pigmented lesion near limbus, and there is a feeder vessels. The lesions are not raised, and the rest of the part is within normal limit. So they asked me, what is your DD? I told it might be case of conjunctival nevus or primary acquired melanosis. I stopped there because I have less knowledge regarding that. So they asked me that how do you differentiate? Then I told if there is a presence of any cystic lesion, it might be a case of nevus. Then they asked me, do you think it is a case of nevus? I told no, it might be a case of primary acquired melanosis. So why you are thinking so? I told there is a presence of feeder vessels and the lesions are near to limbus, and I am not seeing any cystic lesion in a bare eye. So they asked me, okay, if you think if it is a case of primary acquired melanosis, what you will do? Then I ask the patient for any growth of the lesion, and as it is close to the limbus near to cornea and there is a presence of feeder vessels, I will go for excision. I will go for biopsy. I told biopsy. So then they asked what biopsy? I told excision biopsy. Okay. So after excision biopsy, what will do? I told as I am thinking it's a case of PAM, there might be chance of ATP. So I will do after excision biopsy, I will do double freeze thaw technique for the conjunctival wound closure, and I will go for histology and see there is presence of any ATP or not. They asked me if there is presence of ATP, what I will do. I told I will add anti-metabolites like topical mitomycin C. How long? I said 0.04% topical mitomycin C for 4 times for 7 days, and there will be 2 to 3 weeks treatment fee interval. Around 3 to 4 cycles might be needed. So they stop there. So anything else you want to add?
So regarding this, the conjunctival pigmented lesion, why you told mitomycin? This looks benign to me. Why? I don't know.
No,
I'm just asking.
I told that if the histology says there is some atypia, I told like that way. After
Okay.
excision biopsy, if the biopsy shows atypia, I mentioned like that way.
Okay.
If it shows atypia.
Okay.
Any further question? Or I will move to my next questions.
In the above that psychiatrical ectropion, after removal of the psychiatrical tissue, can we go for that? There is mustard cheek,
Flap.
graft.
Yeah,
Yes,
actually,
flap that we take.
yeah. Actually, the discussion was very precise. Like there was, they are giving me like they are shorting my time. Like I can attend more questions. They helped me. They didn't go for the detailing. Just go for management. That like simple 2 to 3 lines I mentioned. You heard. Like removal of the fibrotic tissue and lead reconstructions by either flap, that cheek rotation flap, or whatever else. I am not oculoplasty person, or graft. So they do like that way. But in your time, it might be asked the detailing of this. So the topic is important. What topic they will cover. What are the topics been asked in several, in past experience? No, cover all the points on that topic. Even though you are not of that specialty, but at least you can like that. No, I said the flap or graft.
Yeah. Okay.
So my next table was posterior segment. So the first segment showed me this that right-sided picture, not that one. Only this picture was there. So asked me to describe. So I told it's a partial fundus photograph which shows a spindle-shaped pigmented lesions with irregular depigmented area. Then he asked me, what is your impression? So I directly told it might be a case of atypical congenital hypertrophy of retinal pigment epithelium. So immediately he asked, why atypical? I told, sir, because of the shape. So what typical JRP looks like? I told, sir, in solitary single congenital hypertrophy of retinal pigment epithelium, it is circular, and there will be a definitive margin, and there will be perilesional halo, and there will be intralesional depigmented lacunae. So it is not there. Here, the margins is irregular. It is spindle or oval shape, spindle shaped, and there is a depigmented area, regular depigmented area around the lesion. He was convinced, and then he said, why it is not melanoma? I told, sir, it is not elevated. There is no subretinal fluid. There is no feeder vessels. And assuming the site, melanoma most of them involves the posterior pole near to macula. So then they ask what do you do with this patient? You have seen this. Actually, they want to ask me that association. They ask me what you will do in this patient. And I told that I will see the whole fundus, and I will see the other eye. And and then I will ask for any GI problems to exclude any GI pathology. So they think, what association you think of? I told familial adenomatous polyposis. So what I will do, I will assess the visual acuity as the macula. It's not been shown. If there is any associated diffractive error, I will correct. And I'll keep the patient under observation, and I will refer the patient to gastroenterologist. What they will do? They will do colonoscopy to exclude to confirm poly. So my discussion was over there. And then next picture, they asked me to describe. So I told it is a fundus photo of left eye showing waxy disc pallor, arterial narrowing, and bony specular pigmentation involving the mid periphery of the retina. Then they asked me what might be the symptom of this patient. So I told night vision difficulties, that is nectolipia. So they asked me what will be the other DD of nectolipia. I told night vision difficulty also occurs in vitamin A deficiency, macular dystrophy, rod cone dystrophy, and a significant myopia. Also, there might be a case of night vision problem. So then they ask me, how do you investigate the patient? Assuming it's a case of retinitis pigmentosa, I can do ERG. Here in this picture is an advanced form. Usually in retinitis pigmentosa, I was just mentioning the investigation. I stated I was telling the finding also. Like in early stage, the scotopic part is reduced, but in advanced case like this, the photopic ERG will be reduced. If facility available, EOG if done, it is also show reduced, the response will be reduced. Then I will go for ocular coherence tomography of the patient to see any macular edema. I can assess the visual field to see how much field is being constricted. Then I will examine the patient in slit lamp to exclude any corneal pathology, to exclude any in presence of any cataract. Like that way, I told. So they say, do you want to do? They asked me that it's a female patient. Do you want to do any counseling before marriage? So I then told them, like before marriage, the person whom she goes to marry, that person should be checked properly whether there is presence of retinitis pigmentosa or not. Because if there is a presence of the same disease the recessive form will be like expressed in their next generations. So first we have to exclude that, and then I told that part only. And what I missed, like I told in exam, but now I missed in investigation. I told genetic assessment. So then in investigation, but they asked me why genetics. So then I told to know the pattern of inheritance, and to and particular value in treatment part, some form of RP. Vitamin supplementation is helpful, but in some form not. So if there is a clear cut idea of what genetic defect we are dealing with, so it will help in treatment. So they didn't say anything. So after that, they asked me the worst inheritance pattern. I told X-linked recessive. So they asked me what the causes of decreased vision in this patient. I told the cause is optic atrophy, might be macular edema, or sometime cataract, and very rarely keratoconus. So they stopped there. They didn't ask me further. And they showed me third picture. There's a almost 0.9 calf, and there is a peripapillary atrophy. So they asked me to describe that. I described. So they showed me the area with pen. So one first with that disc, the first concentric zone, they showed me what is this. I told beta zone. They asked me what it signifies. I told atrophy of retinal pigment epithelium and choriocapillaries. Then they show faint circle just adjacent to that. The what is this? I told alpha zone. What it signifies? Here it is hypopigmented area around beta zone. So what they signify? I told medicine. It signifies it's a progressive glaucomatous optic atrophy. Okay, so they asked me what investigations you will offer to the patients. I told I will assess visual acuity. I will assess intraocular pressure by Goldman applanation tonometer. I will do gonioscopy to see the angle. I will investigate, like I will do the central corneal thickness. I will do the field test, like 24-2 and 10-2, and I will do ocular coherence sonography, RNA film. So they asked me what is the importance of CCT. I told if the CCT value is low, the IOP measured will show falsely low. So low CCT is a risk factor for glaucoma, as it we can as the IOP will show low, we can feel that IOP is controlled. Actually, no, like that. If the CCT in lower side, we have to be careful. We have to adjust that IOP, and we have to treat them accordingly. So in this patient, what treatment you will give? So I told if I will ask the patient whether it is a NAPE case, or like it is been patient is receiving anti-glaucoma medications or any surgical options prior. So they told me it was patient has been diagnosed as glaucoma first. So then I told them I will offer anti-glaucoma medications like prostanoid analogs, excluding contraindications, and topical beta blocker, alpha agonist, and carbonic anhydrase inhibitor, excluding contraindications. They asked me, you will offer all the medications first. Then I told them as assessing that central corneal thickness, intraocular pressure, and the degree of damage. Initially, I will offer a mono, as patient is not received, and IOP is if IOP is high, I have to go for duotherapy or triple drug. But if it is just upper range, then I will go for monotherapy, and I will quickly assess the patient. Then they ask me that they didn't ask me anything. They go for next question. So before that, anything you want to add? Nothing. Okay. So I am moving to my next question. So my next question is the picture showing like this. Then they just tell me what will be the cause of this condition. So as the picture shows neovascularization of iris, and I told the cause might be central or branch retinal vein occlusion, proliferative diabetic retinopathy, ocular ischemic syndrome, central retinal artery occlusions, and sometime chronic retinal detachment and chronic intraocular inflammation involving the posterior segment. So then they told me that what treatment you will offer this patient. Then I asked them what is with the vision. They told me both side. You can say patients might be like there is no there might be PLPR, or there might be visions like 636 or 600, like that, both way. So then I started with that if the vision is non-salvageable, then I will think of whether there is a pain or pain present or not. If there is presence of pain, I will first, if the vision is not non-salvageable, I will offer the patient with cyclovigic, topical steroids, and anti-glaucoma medications, and I will assess the patient whether pain is present or not, pain is subsided or not. So if the pain is not subsided, what are the treatment options I will offer? Like I will offer cyclocrioablations or diode cyclocrioablations or diode laser cryoablations. If not improved, I'll offer retrovalvular alcohol injections. Then if not improved, then I will offer eviscerations. And if the pain is controlled with initial primary management, I will continue the treatment and observe. Then again, I will jump to that next part, that if the patient vision is salvageable, then I will assess the IOP. If the IOP is not raised, I will give only I will give topical steroids, cyclopegics, and I will, as the media is clear, I will offer the patient pan-retinal photocoagulation. And yes, so and then I jump to, if the IOP is raised, I will add anti-glaucoma medications, excluding contraindications. I will avoid personal analogs and pilocarpine in this patient. And then I will offer pan-retinal photocoagulation, and if possible, I can give anti-VEGF also. So if the condition improve, I will continue the conservative treatments. If the condition not improve, then I have to offer some surgical treatment, like trabeculectomy with antimetabolites, explaining the chance of failure, and or we can offer glaucoma drainage device. So then they, after telling that, they asked me, what PRP you used to do? You do PRP? I told, yes, I do PRP in Pascal setting. So my setting is like power, I used to range from 250 to 500 milliwatt, and the size is 200 to 400 micron, and the duration is 20 to 30 millisecond. So yes, so after that they move to next question. And they given another scenario of glaucoma. So they have given 80 years old lady diagnosed as a advanced glaucoma, don't want to put any drop. So what treatment option will you offer? Again, the repetition of the previous question. Then I told that option, I will offer surgical treatment like trabeculectomy. Then they asked me, patient don't want surgery also. So what else you do? No drop, no surgery, 88 years old. Then I told that I can do laser trabeculoplasty. So they asked me what trabeculoplasty you will offer. I told selective laser trabeculoplasty. They immediately, do you know the setting? Then I told that the spot size will be 400 microns. The power will be 0.3 to 1 millijoule, and the duration will be 0.3 nanosecond. And the treatment is offered like 180 degree 50 spot. So they asked me next, what complication you will suspect here, you will think of here. So I told there might be mild anterior chamber inflammation, with mild raised IOP. So what you will give? I told I will give mild steroid and anti-glaucoma medications to combat that initial complication. Okay, then they move to next question. They show me a picture post-op and there was shallow AC. Again, a gross question like management in detail. So immediately I asked that I want to measure the IOP. If the IOP is in lower side, I have to see the bleb and I have to stain whether there is schedule positive or not. If it is schedule positive, then it is a case of bleb leak. And then I have to stop the steroid and I have to give cycloplegic antibiotic and I will do pressure at pad bandage for at least 1 to 2 days, and I will observe the patient again whether the bleb is forming. If it is not forming, still it is there is leak, I can offer bandage contact lens with or without pressure bandage, and again I can think of the bleb revision. So if the schedule positive is negative, then I can go for, I will offer the patient the same way, like stop steroid, give antibiotic and cycloplegic and topical beta blocker. I mentioned earlier also topical beta blocker in the bleb leak part. Now in the overfiltration part, again I have mentioned the same thing like topical antibiotic, cycloplegic and topical beta blocker, and first pressure bandage, pad bandage, like the same way, 1 to 2 days. If not improve, I can give bandage contact lens 3 to 5 days. Not improve, I can go for compression, conjunctival compression suture. Not improve, go for bleb revision. Then if there is no overfiltration, there is no bleb leak, I will see the fundus there to exclude the choroidal detachment. If usually we used to give conservative treatment initially like topical steroid, cycloplegic, and antibiotic. If doesn't heal within 1 to 2 weeks, we can consider oral steroid excluding contraindications. So then they stop me. They don't allow me to say the high pressure wala part. But in exam, you should be prepared for high pressure part also, like pupillary blocks, suprachoroidal hemorrhage, aqueous means detection. They don't allow me to mention that part. Okay. So my next question was like it's also a scenario. A picture. They're showing conjunctival congestion, mild corneal haziness. The little bit of it's not that much hypopen. Angry looking eye. So the scenario was describing that there's a post-injection case. So they asked me, what is your DD? So I am not seeing that much of hypopian, and with that picture, I was not confident of endophthalmitis. So I said it might be a case of post intravitreal injection, intraocular inflammation. There's an entity. So they told me, if it is so, how will you manage? So I told them that first I have to examine the posterior segment, the vitreous, the media, to exclude the whether it's a dense vitreitis or any endophthalmitis. If it is not there, if it is a case of only post-injection intraocular inflammation, I will give topical steroids and cycloplegic and observe the patient. Most of the time it heals. So then they asked me that if you see the media is hazy, so what you will think of? So I told that assuming the visual acuity and the scenario, it might be a case of endophthalmitis. So then they asked me how will you treat? And then I told if the vision is more better than hand movement, I will offer intravitreal ceftriaxone and vancomycin and observe the patient 1 to 2 days. Then if the vision is improving, I'll continue my medicines like I'll give steroids, topical frequent antibiotics. We can offer fortified antibiotics, cycloplegics. If there is improvement, I will continue that. If there is no improvement within 1 to 2 days, then I will consider core vitrectomy along with intravitreal antibiotics. So they asked me And initially, I told taking sampling also. The initial injection part, what I told, intravitreal vancomycin ceftazidime, that I told I will first take the sample from AC or vitreous step and send for histopathology, and I will give intravitreal ceftazidime vancomycin. This discussion was going on like that, and then I told like if the vision is not improving, then core vitrectomy intravitreal antibiotics. Then they asked me if the injection was intravitreal steroid, like Dex implant. What will be your impression? Then I thought for a while, and I think it might be a endogenous endophthalmitis. It might be a case of fungal endophthalmitis. So immediately when I told fungal endophthalmitis, they told what treatment option you will offer. So in that case, I told them if it is a case of post Dex implant implant endo, then considering fungal, I will add intravitreal voriconazole in this patient, and after the histopath after HP report, if it shows it's a candida, then I have to add intravitreal amphotericin B also, and the rest part are same. So here my answer is they stopped there. So my first day completed like that way. So if you want to add anything. Today up to this, I will cover up to this, not more. You can ask this part also or as a whole also.
Right. So there were no particular questions about the gauge of the needle for the vitreous tap or anything like that.
No. They didn't ask, but they can ask. Actually,
Okay. So we should
yeah,
look it up, but it's not very necessary. They didn't ask you, but we should know about it, right?
yeah. You endophthalmitis, you should know everything.
Right. Yes.
But that means the topic which has been asked in regular repeatedly, you should know every point of everything.
Right. Yes. Thank you.
Anything else? Okay. Someone please uh, take this number 6 question. Shallow AC. Actually, they allow me to tell only the low IOP part. So anyone can volunteer and tell that high IOP counterpart of that shallow AC post trap. Dr. Mariam, I think you
Yes,
are
sir.
only active here today.
Right. The three conditions that I can recall, one is suprachoroidal hemorrhage, and then aqueous misdirection, and the last one is mm,
Pupil block glaucoma.
yes,
Yes.
pupillary block. Yeah, these three.
So, Mariam, just I want to ask other. Just let me
Right.
see
Right.
who are there.
It's
Okay.
pupil block.
Yeah, Dr. Asma.
Yes.
One part. You will take pupillary block. How will you manage?
In case of pupillary block, if it is there, the AC will be shallow and the serial test will be negative. The pressure will be very high.
AC shallow. What will be the nature of shallowing of AC? Actually, there is difference between that aqueous misdirection and
It will be iris Bombay. The
will you say iris Bombay or something else? Peripheral shallowing, central deepening.
Okay. Peripheral shallowing.
It's a peripheral or mid peripheral shallowing. Central, but a little bit not deep. You can say peripheral and mid peripheral shallowing with centrally little formed AC. It's not deep.
Okay.
It's a form AC. You can say like that. So
Fine.
how will you treat?
And so main pathology is because of the pupillary block. So we will do the YAG iridotomy so that we can make a passage for the aqueous to solve the pathology, and we will give the anti-glaucoma drugs and cycloplegics, and this is what we will do.
In pupillary block, will you give cycloplegic? If you think cycloplegic is a routine part, but if you think pupillary block, you
Mainly it's
can continue,
I thought
but it's not mandatory. The PI, you have to do a PI, you have to complete that PI. Otherwise, so don't just you can what you said in the proper way, but the PI, you mentioned PI.
yeah, I just said that the first thing is to do the and Yagless peripheral
Okay.
eye dot.
Okay. Dr. Tamini, are you there? Yes, no.
Yes, I'm here. I'm here.
Yeah, so next take aqueous misdirection part. I will treat.
Okay. So aqueous misdirection, I will
How will you
first of
how will
all,
you think it is a aqueous misdirection? What picture will give you the clue? It might be a case of aqueous misdirection.
so aqueous misdirection will have a shallow anterior chamber, very high intraocular pressure with the patent PI.
Yes, patent pay 1 point. Other.
Shallow anterior chamber, high IOP.
What will be the nature of shallowness?
The entire anterior chamber will be shallow.
Yes. Okay, fine. So
Uniformly shallow. Yeah.
how will you
So
treat?
so if the patient is pseudophakic, then I will try to disrupt the anterior hyaloid face by doing initially I will give IOP lowering agents and I will give atropine and I will try to lower the intraocular pressure with IV
Only atropine?
itazolamide.
Actually,
Atropine
in
and
exam hall, you have to be very like stepwise.
right.
You have to tell all the points. You know all the
Right.
points, but you have to tell all the points. Tell.
So I will give topical atropine. I will give topical carbonic anhydrase inhibitors, topical beta blockers, and also um, I will do a YAG laser.
No. You have to mention steroid also. Topical steroid also required.
Yes.
Yeah, it's
Yes.
required. Then.
Yes. Then I will give this. Then I will go for to disrupt. The main aim is to disrupt the entire hyaloid face.
Yeah.
To redirect the aqueous flow. So if the
Okay.
patient is pseudophakic, I will go through the I will do a YAG laser hyalodotomy. Otherwise,
Yes.
I can go through the
In
patent PI also.
pseudophakic, where you will do, and in phakic, where you will do.
Okay, so in pseudophakic, I will go through the pupil behind the lens, and in phakic patient, I will try to go through the PI through the zonules. I will do a YAG.
So, even after that, not managed, what you will do?
Okay, so even if that is not controlling it, then I have the option of going in for a core vitrectomy to reestablish the aqueous flow.
Okay. You are just okay. If it is a pseudophakic case, even though it is not been established, what you will do? It is theoretical question. Last part is theoretical.
Again, what's the question? Sorry.
You have done vitrectomy. On table you are assessing, but still not been controlled. Like is he still shallow? You intraoperative you measured IOP. IOP is not that shallow. What you will do? It's
I don't know.
theoretical. It will not have been asked. You can remove the IOL also. Okay.
Okay.
So
Yes.
yeah, like 3 part you can read hyaluroniectomy, vitrectomy, and lensectomy. Let's not lensectomy. What I say, Dr. Kaushik might say better. You can remove the IOL also. It's a theoretical. It's not required. And the last part, the suprachoroidal hemorrhage, has been discussed in my prior discussion. Okay. So yeah, just quick recap of that. I'm leaving this number 6 question. I am just focusing number 7 question now. So what is the dose? What is the dose of intravitreal antibiotics?
You're asking me 2 milligrams per 0.1 ml.
Yeah, anyone other one, other candidates?
Yes, sir.
Yeah.
Yes, doctor.
Yeah, please.
2 milligram. Yeah, 2 milligram 0.05 ml.
0.1.
I have to give
Ceftazidime and
Confirm.
vancomycin, which?
Yes, ceftazidime and vancomycin, yeah.
Now, I think in new Kansky also mentioned this way, na? All are agreed to that?
Yeah.
Or anyone have another option, any opinion, other opinion? Actually,
Yes.
yeah, Tavina.
Amikacin, that it is retinotoxic. So
Yeah,
it
I'm
has
not
been
asking
used
Remicacin.
in
I'm just asking about, yeah, it's retinotoxic. Ceftazidime, all try to read all these dose. Dose is very important because you are the surgeon who you need to give the antiviral. Okay.
Okay, what
Mhm.
about the dose for this voriconazole?
Actually, I have forgotten now. Just I am
Okay,
telling you
but
people, just remember all this money, note it down. Somewhere it is noted.
hmm,
If you allow me, I
hmm,
can see my text and I can it will be available.
okay,
It's better not to say
hmm,
the wrong amount.
hmm,
Yeah. And now I think we used to do it earlier, Vanco 1 milligram and Septa 2.25. But now it has been changed. In
yes, now it's two for both.
it's two for both. It's easy to remember.
Yes.
Okay. And end of you should not leave a single point.
Hmm.
End of you
So-
have to know.
So do we need to know how to make the dosage also, like ceftazidime and vancomycin?
You actually they might ask. Keep a
Okay.
chart
Mhm.
and or somewhere you can see it regularly or some like it will be regular. Sometimes it's not easy to remember. No. Okay, but
Mm.
it is required how to prepare that. The chart is available in net. And so
Okay.
just write it down and just fix it to somewhere where you can see. Okay.
Okay. Okay.
Okay,
Thank you.
and then in glaucoma, like they can ask every point. Like we
Mhm.
all know that anti-glaucoma medications and detailing of all the medications, side effects. I'm just asking you some questions. What are the side effects of prostaglandin analogs? What are the side effects of prostaglandin analogs? Anyone? Just randomly, don't kill your time because your time is very important, including me
It
also.
can cause cystoid macular edema, or it can aggravate the inflammation if the patient is having inflammation
Most of the
prior
time in
to.
inflammation, we avoid this. So
Right.
don't say this is a first complication. You can add this later, but what common side effect we used to see in our patient?
Hyperpigmentation, psoriasis, and
Yes, yes,
hypertrichosis.
Hyper,
yes,
right, right.
yes. And then the point like exertion of inflammation, exertion of macular edema,
Yes.
all these things. Okay, fine. What is the complication of what are the complications of topical beta blocker?
Hypertension, nocturnal hypertension,
No,
and
beta blocker, how it can cause hypertension?
hypo.
You say hypotension. Okay, okay.
Yes.
Okay. Then
Yeah. And so aggravates asthma also.
it should be mentioned up first. Aggravation of asthma, COPD. Then
Mhm.
where to avoid? Any heart block?
Yes, and heart block. Yeah,
Okay.
and any
So
heart
yeah.
block.
So you can say that
Heart
also,
failure.
na?
Mhm.
Okay, fine. What are the side effects of topical alpha agonist? Someone new. I'm just
In
asking.
in children, it can
Yes,
cause,
yes.
it can cross the blood-brain barrier, so
Yeah.
it should avoid it. It can cause tachyphylaxis. It can cause has a drug interaction with monoamine oxidase inhibitor, so should be given carefully with that, and can cause
I am
conjunctivitis.
not sure of that part. That
Okay.
monoamine oxidase inhibitor. You just
It's
confirm it, check it whether it
yeah.
is. Other point, important point. You mention on next. You can see though it is
Allergic
there.
reaction
Yeah,
is common with
yes,
this alpha agonist.
yes.
Contact dermatitis.
What is blepharoconjunctivitis? It is a very commonly
Blephroconjunctivitis,
encountered thing.
follicular conjunctivitis. Yeah.
Yes. So mention this. What you mention, child, CNS depression, it might be the first or second statement. First statement should be this, first or second statement. Okay, in exam hall, you should tell all the precise points. Okay, blepharoconjunctivitis. Second, you will see Kansky, there might be granulomatous uveitis. Because in my practice, I have seen 3-4 cases of granulomatous uveitis after brimonidine. So read. It is an interesting point. Okay, real world scenario. After that preparation, no, that FRCS preparation. Before that, I had not idea of that. I like that all this CNS depression and like blepharoconjunctivitis. But you can see in Kansky it has been noted, and I have seen after stoppage of this. And with sometime even with if you give steroid and continue that alpha agonist, it's not clearing. So with the mild steroid, even glaucoma you can give steroid too much. Why? In if you're dealing with primary open angle glaucoma case, some issue you compelling you to give steroid, you have to be very precautious. Why? All the PUAG case, almost 90 to 95%, they are steroid responder. So in one of my case, no, there is I think several, 3-4 cases. The patient present to me, patient was on glaucoma medications. There is mild uveitis and KPs. So I was thinking of there is no such history with such a 60 years old posterior segment, no media is clear totally. What might happen in this age, 70 years? Why there's uveitis? There is no prior history. So after that FRCS preparation, I read that part, that granulomatous uveitis, non-granulomatous segments. So I thought it might be case of brimonidine. I stopped it, magically worked. I am telling you. So it is real world scenario, how FRCS preparation helped me in my daily practice. You will all clear that this exam, but the thing is that the preparation will matter. It will change your practice pattern. Okay. So it's an important, you know, all the side effects of CI also. I am not discussing. Okay, fine. So they want in glaucoma, they want every option. We all focus on drug and surgery, but also laser trabeculoplasty. They want that also. Okay, fine. And in PI part, PRP and mentioning the anti-VEGF also. Because when we consider anti-VEGF, I am telling you, like we have done PRP, IOP is not controlled. So we are planning to do a trap with mitomycin C because GDD is costly. Some patient cannot afford. Sometimes with poor social condition, we have to offer trap with anti-metabolites. So prior to that, in our hospital, sometimes we offer free vials. Sometimes there's some extra after giving injections, few injections, there's some extra amount is left. So we offer them that free vial anti-VEGF prior to the trap, like 3 to 4 days or 5 days prior, we give anti-VEGF, excluding contraindication. Before giving anti-VEGF, we should exclude contraindications. What are the contraindications? Macular threatening lesions, some NV involving the vascular arcade, temporal or superior inferior vascular arcade. If florid NVE is there, here you cannot give. Why? Because if intravitreal injection has been given, there will be fibrosis of that part, and that may cause tractional RD later. So any macular threatening NVE should be avoided. So if it has not been there, you can offer anti-VEGF. Anti-VEGF should not be offered to each of the patient. Prior to any surgical treatment, we offer. So you should know, even though you don't do PRP, you should know the PRP setting also. And in exam, you can tell like that your own way. Like in my hospital, you are not a retina surgeon. Like I am telling you, you're ocular specialist or you are entrance segment specialist. So you can say in my center, my colleague used to do PRP in Pascal laser or like that setting. You can say that way also. It is not mandatory that you are doing, but you know that part. Okay.
Okay.
Yeah, and RP, they used to frequently ask, do know everything of RP? I am just asking one point. Like in RP patient, what I saw, I explain, like causes of decreased vision. So if the decreased vision, the cause is like macular edema. So how will you treat this macular edema?
Oral carbonic anhydrase inhibitor, and maybe
Excluding
also topical.
contraindication, always mention this word, because you cannot give offer oral CI to the patient who has sulfur drug allergy, no?
Yes.
So
Or renal.
always mention such kind of statement. This is a very easy, like steroid. I told in my previous class also, before telling like steroid also, excluding contraindications. Say like that. Okay. And then
Okay.
topical carbonic anhydrase inhibitor can also be
Topical.
given. If it is a
Yes.
case of it's a posterior subcapsular cataract, what you will do? What you will offer?
Phaco surgery.
Prior to that, refraction, refractive correction. If visually significant cataract, you will go for phaco surgery. In phaco surgery, what point you should remember? There is chance of jonular dehiscence. You should be prepared for that. Okay. And in eyes, I told in cornea what to be examined. If it is it's a child or like age between 10 to 20 years age.
Look
In
for
cornea, what?
keratoconus.
Keratoconus, fine.
Yes.
Yes, and yeah, okay, fine. And what in treatment part? What treatment you will offer? Actually, it has been asked in my OSCE case. I had a same case in OSCE also. Different patient. One is like scenario is different. Next day we will discuss it. The treatment part they discuss there. Okay, we will discuss it there.
I'll give glasses. You mentioned, I think, is a previous class about amber glasses that block short wavelengths.
It's
Yes.
actually some nano control nanometer control glass, something like that. So which filters the blue light.
In Kanski, its name is amber glasses.
Mention Kanski each and every word. Yeah. Say they don't want anything more than Kanski. Kanski enough. Okay. Charpy is good. You and all the pigmented lesions, try to read all the lesions, because these are commonly asked. And the entropy and ectropion, they will give either ectropion, either entropion. You should be well prepared with that. And the mass will be given, and they ask me histology. Okay. Usually in previous experience, I didn't get such kind of experience like asking histology. So sometimes they are now asking histology also. So don't go through histology in details. Just salient points. Actually, I rate. So I forgotten that suddenly keratin field crater is I remembered. So like that way, you can skip that part. Just read the salient points regarding histology, and lead reconstructions will be asked to each and everyone, the in treatment part. Okay. And barn is okay. Actually, barn, they might not mention that alkali or acid. They can ask like chemical injury, then you can follow like that. Okay. And AC shallow posterior. What Dr. Kaushik mentioned, no, that USG. I told actually USG because routinely in any mature cataract we used to do. Actually, I forgot to mention here. But
what is the nasal thing? Just nasal corneal what thing? Any other candidate? There is cataract, but in cornea there is some whiteness. No, what is
maybe band keratopathy, starting band keratopathy due to chronic uveitis.
Because in both the sides, or in the other side also is there. So if it is in young, like 7-year-old kid, what could it be? What could be the diagnosis? Seminar?
Juvenile idiopathic arthritis.
What?
I'm thinking, sir.
Yes.
7-year-old.
7-year-old, well, yeah, female with this kind of picture in both eyes.
JIA?
Yes, you have to rule out JIA and any history of knee pain, etc.
Oh,
Dr. Kaushik,
Yes, Dr. Avijit.
what happened? It is
Okay, so what means? Actually, my connection was poor.
okay. Then
But did you stop sharing?
no, I haven't done anything.
I also did not do anything, but the share went away.
Okay,
Just
okay,
please
okay.
start sharing it.
Yeah.
Yes, we can see it now.
Uh, Someone say it's not exam. No, try to participate. I used to participate in my time, even though wrong, right? I learned a lot. What Dr. Kaushik asked,
What is the question?
Dr.
yes. I think he asked about uveitis in children. Yes?
No,
Yes.
he asked about that lesion, that the nasal and temporal lesion, the iris.
Is it not band keratopathy?
What, Dr. Kaushik?
Yes, most likely it is band separate keratopathy in both sides, because
Yeah.
it's like typical interpalpebral location, and there is some sparing around the limbus, and there is
Yes.
cataract, uveitic cataract, posterior sinica, etc. So, BS most likely it is band separate keratopathy.
Though it is not that obvious, but the band-shaped curve starts from these two sides. No, that long-standing uveitic case, child or middle-aged.
And also central corneal haze is there. If you see clearly, there is some central corneal haze also.
Yeah.
Hmm. So this is a
Yes.
chronic.
Now that you mention it, yes, it's there.
Actually, in my exam, the case was not like that. Actually, I have taken from somewhere else just to resemble the scenario.
Basically, I'll request candidates to see all kinds of images. Try to find out what you can like deduct from the image itself. So this because ophthalmology is a very like visual subject, like dermatology. So if you take interest, you can actually see the atlases and just close the hide out the legend and try to understand or try to describe the image yourself, and then say the legend or see the legend. If you do like this, then you will learn a lot. Specifically, retina people, if you can do this, like if you can open an atlas and if you can see an image and analyze it yourself and then deduct your diagnosis and then see the legend, and if you can match it, nothing like that.
I think in Kansky, some atlas is there. Kansky. Okay, just pictorial presentation and regarding that,
Actually, Dr. Abhijit, Kansky has multiple books, and all books are extraordinary. So,
beautiful.
yes, and in Telegram, almost all books are there. So there is a atlas, there is a like MCQ type or a OSCE type book also, in which there are situations and the candidates like there are questions and the answers are given in a later page. So
I am telling you one thing,
uh,
that keratoacanthoma part, how I can able to answer these risk factor in Kansky Atlas. Actually, I am not, I couldn't able to finish that whole part, but still just cross quickly. I have seen that picture. So there was a case of keratoacanthoma. So usually don't read in detail that risk factor, histopathology, but in that question they ask. So I remember that immunosuppression, renal transplant, like that, and the keratin filter. Actually, in routine regular reading, I didn't read that part. So when I was preparing that Kansky wala thing, so then I read and that clicked in my exam hall. And here, lateral rectus palsy wala thing, no, six-nerve palsy. It will be asked like almost, I think, in my past experience, past experience may, I have seen lots of times been asked. So, lateral rectus palsy, six-nerve palsy,
Basically, six nerve palsy, third nerve palsy, and superior
seven.
palsy, every superior palsy and seven palsy. Anything can be there. If there is a tilting, you have to understand that most likely it is a superior palsy. If the photos are showing some tilting, right head tilt and left head tilt, but you have to understand which side is it. It is. So this palsy and their haze chart and they are this 9 gauge photo. These are very important questions in FRCS, and most likely one or another palsy will come.
Yeah.
FRCS,
And
yes.
describing the picture, no, try to actually sometime in exam we used to puzzle what to say. Don't go for directly. Just describe every point very quick manner. Primary, levo-dextro, and dextro elevation depression like that. You can see. Sometimes there might be mixed picture. No, when you say
Sometimes they can give Brown also, Brown syndrome. So
yeah,
basically, if you can see like superior right levo elevation, dextro elevation, if you see, it will be very prominent. But do not like hurry. Ki, haan, I have
yeah.
to tell it immediately. If you hurry, then you will make.
And then like this in this case, don't go for like it's left-sided lateral rectus palsy, six-nerve palsy. Don't say like that way because it might be possible either way. No, so always stepwise but quick. In exam, time is very less. You have to be very quick and precise. So tell it very quickly and just they will proceed. If you say directly, no, it will give you wrong impression. And in such case, lateral rectus palsy, like the way I mentioned, like life-threatening, because they want safe surgeon. No, because if you don't know the life-threatening part, it will be difficult. So you should know you should take care of the life-threatening part also very quickly, very like without any delay. And this, so it's a very common thing. Actually, I'm not a screen person, but when I started reading, I started with this. Salient points you should not miss, as they don't ask me the treatment part, like surgical options. You should know because discussion may go on that way. So anyone can anyone can discuss the surgical option. Even though there might not be any screen specialist, but try.
So we can, I'll try. We can do medial rectus recession and lateral rectus resection. And
Say
I think
like
we
which
have to
eye?
start by lateral medial rectus recession.
No. Both same. No. What Dr. Temina said. Repeat again.
I said medial rectus recession and lateral rectus resection. If it's a
Yeah.
unilateral case.
Yes. If it is a unilateral case, but the same scenario might be given like both eye. So then you have to.
Then bilateral medial rectus recession is preferable because ek to it's reversible, dusra it's secondly it's it gives more symmetrical results.
My question is, what is both eye squint? There is nothing called both eye squint. Both eye
Yes. Yes, then we will go for bilateral medial rectus
No.
recession.
I'm asking, you cannot say both eye squint. It will be called
Alternating.
alternative.
Yes.
So do not
Yes.
say both eye squint because both eye
Right.
one eye will be fixed, so that cannot deviate. So both eye
Yes.
squint is something which is wrong. So you will have to
Right,
say
right.
unilateral squint, and if it is like alternative squint, then
Alternative.
you can do bilateral. Yes, and
Doctor,
there are other considerations also, including in inferior oblique overactions and amount of squint. Amount of squint is also important. If it is very huge, it may not be possible to correct it in a single day. So
yes.
you have to tell in a like what are the preoperative considerations you will take, and also the accommodative part of the squint. Like
Mhm.
you
Right.
have to try the glasses, etc. Cycloplegic refraction, then only you plan to like go for surgical intervention. So basically,
Right.
even if you do
Hmm.
not know like exact how many millimeter, etc.,
Hmm.
but you need
Hmm.
to understand the logic of the treatment. That's what the examiner will want to know.
Actually, in our class, screens, sir told like that way, like you can correct 20 to 25 prism diopter with one muscle maximum. Like you
Yes,
can.
so I mentioned here bilateral medial rectus recession because I see that it is huge angle.
Okay, you okay, you told in that way. So yeah, so how that means like if it is like actually in my case it was in between the light reflex, it was in between actually. So you can say 60 prism diopter. So to correct 60 prism diopter, you have to mono muscles will not correct it. At least duo muscles will not. It's 20-25. It's three muscles you have to touch almost like that way. So you should clear it, because in exam say blindly better to understand what actually you're seeing. Okay,
Mm.
at that time I understand that part, what actually you have to do, like this much actually one muscle can correct 20 to 25 prism diopter correction. So like that way. Okay, you can ask in screen class, there will be like good delineation. It's not a fixed one.
My question is this: left eye looks a little elevated, no? Why is it?
Actually, Dr. Kaushik, it is not, it is a prototype question. My question
Yes,
was
yes, we
straightforward.
understand that. Yes.
No. Just,
There is some inferior oblique overaction
yes.
probably.
There is
Yeah,
some
yeah, yeah.
probably over
Yeah, yeah, yeah.
So, basically, these are some things you need to like keep in mind if it is asked.
Yeah, yeah. And for inferior oblique overaction, what to do? For deviated vertical dissociative vertical deviation, what to do? You have to know. At least inferior oblique overaction, you have to do inferior oblique weakening procedure. And dissociative vertical deviation, you have to do. You have to weak the elevator. Vertical deviation, no. So elevator should be weakened. Like that way.
Mm.
And this optic neuritis part, like you should cover with age also. No, young, you are thinking of optic neuritis. If it is been age, the picture will be not the same.
And also vision. Dr. Abhijit, such
Yes,
vision is also important. So
yes, the triad, no, decreased vision. If you're thinking of optic neuritis, vision will be decreased. There will be some pain and there will be decreased color saturation.
and sometimes there is a like you can be confused between the pseudo disc edema and true disc edema, like papilledema and pseudo papilledema. So in pseudo papilledema, usually vision will be very good. So also, how do you differentiate true papilledema from pseudo papilledema? Anyone? Dr. Mariam?
Sir, I can get a B scan to see if there are any buried
No,
optic
no,
duct.
no, 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 no. Not go there. Just whenever you
But
are asked a question, you
examination
May
first.
I?
yes.
In autofluorescence, I think you can see
No,
if
no,
there's any
no,
buried
no, no,
lesion.
no, no.
Basically, on
When
examination of the disc,
yes, my question
there
was
are no
following.
dilated tortuous
Hmm.
vessels if there is pseudotosis, although the disc is blurred but not highly elevated as in papilledema, and the blood vessels are of normal, not dilated tortuous vessels. There is no hyperemia. So these are the few points on examination we can differentiate.
I think we need to read more. So somebody will post how we like the degree of elevation can vary with both the cases. So you cannot differentiate based on the degree, like severity of this thing. Definitely hemorrhages will be more suggestive of papilledema, and the constriction of vessels. There will be pressure on the vessels which are coming out of the disc margin. If it is true papilledema, then the vessels can be a little compressed at the margin, and there might be patterns lines. Which are what is pattern line, Dr. Tehmina?
So there are circumferential lines temporal to the disc
Okay.
in raised
No, in any kind of papilledema.
In any kind. Okay, in any kind of disc edema.
So basically, I'll request one of you, Dr. Hemina can do it. Just find
Yes.
out the clinical differentiations between a
Right.
true papilledema and pseudopapilledema. This is important.
Okay.
It
Okay.
should not be dependent on the degree of the elevation.
Right.
Mm.
Okay.
And the medicine part, I think we have to read more and more, because they don't answer,
Mhm.
they don't want us to answer like a specialist, like critical care specialist. At least they want us from that basic things we know. At least for survival of patient, we'll do the basic thing.
Basically, patients should not die in front of you. You should be able
Yes.
to salvage the initial part, and you should be able to send the patient to a person who is better equipped and who has better knowledge to manage it. Basically, patient should not die in front of you. That is important. You
Yes,
should be
yes.
able to at least give the initial care so that a life can be salvaged.
So, okay, Dr. Kaushik, we can stop here.
Yes, yes. Thank you, Dr. Avijit, for your time. Actually,
Thank you.
we have
Thank you, Dr.
I
passed.
should thank you very much. Like, for you and the whole team, no. I have get the opportunity to present here. So, like, it's a very immense pleasure to be here.
Thank you, thank you. And I'd request all the candidates to please prepare hard. And if you pass, please try to guide other people so that they can.
I'm just telling you, Dr. Kaushik, like, what I felt, the exam per se was not too difficult. Sometime it like some table somewhere might be you are not that up to like up to the mark. So don't be disheartened, because they will not be here to fail you. They
Yes,
are here to judge you.
yes,
Just
they
whether
are to pass you. Basically,
they
they are
are
to
to pass
pass.
you, pass you.
They
So
want to. They will give you clues. They want the keywords. Like if you can utter the keyword, then they'll spare you. And there will be another examiner who will try to help you. Ki, please say, please say. If they understand that if a patient can become blind in your hand or a patient can die in your hand, then they will definitely not pass you. So that is the major thing. You should not miss anything which can harm the patient. So that is
yes,
what this exam is all about.
yes, yes, yes. Okay.
Thank you. Good day. Good day, everyone.
Good day, all.
Thank you.